Good morning, good morning. So, welcome. Let's go ahead and get started. If you'll grab a cookie over here, coffee in the back, and then find your seat, we'll go ahead and get started. I wanted to start with a quick introduction. As most of you know, to become a Stephen minister, one must complete 50 hours of training on topics including the art of listening, feelings, boundaries, confidentiality, crisis theory, and much more. But the training doesn't stop there. After the initial training, ongoing continuing education helps our well-trained Stephen ministers stay engaged, and be better prepared to provide the best care they can for the care receivers. PPC Stephen leaders arrange ongoing continuing education, and when appropriate, we share the information with the congregation to expand everyone's knowledge and to help us all effectively care for each other. Last year, Stephen Ministry offered continuing education that involved helpful information on hospice and palliative care, as well as dementia, topics that are likely to touch all of our lives. This year, we're offering continuing education built around the Stephen Ministry book called Cancer, Now What? It's written by Dr. Kenneth Haugk. He's the founder of Stephen Ministry, and he describes the book as a practical guide for those with cancer and their loved ones. We're fortunate that our newest Stephen leader, Becky Boeschel, is a Master of Science in Health Sciences. She is certified physician's assistant and an associate professor in the Department of Physician Assistant Studies at the Levine College of Health Science at Wingate University, where she teaches undergraduate and graduate level courses on various topics, including those related to cancer. So please give Becky your attention as she helps us understand cancer, its impact on our lives, how we can help care for those with this malady, and how the medical field is changing to provide better treatment and care.
Thank you.
Thank you, Becky.
Thank you. Good to see everybody this morning. I appreciate you being here, and I'm excited to be here. And I just wanted to take a moment to give thanks to all of you, to thank the congregation, to thank my fellow Stephen leaders and Stephen Minister training class for their support of Bob and me over the last few weeks. I had an accident in April, and sitting on a perch today, still rather walker dependent. I broke my ankle and also my femur of my left leg. So I have been a care receiver these past few months and have benefited from the generosity and the gifts of this church. Your prayers have truly lifted both Bob and me up. I have felt them every week. Your visits, your phone calls, your texts, the meals. We've got great chefs in this congregation. You all know that. I just can't express enough how every grace that you extended, I accepted as a gift, and I'm so glad that I can call this place home. So just wanted to say that. And in some small way, it's a pleasure to be here today. Maybe to give back a little, to share some of what I have learned over the years in my studies, and also working in the field at Medical College of Georgia. I worked as a physician assistant in pediatric hematology oncology. So in that role, I was taking care of patients, and because they're very young patients, I'm also interacting and essentially taking care of family members. And that experience actually was the highlight of my clinical career. I just teach now, but that experience, taking care of children with cancer, was the highlight of my clinical career. So I'm truly excited about this. This is going to be interactive, I hope. And so I may also, to preserve a little bit of my voice, I may invite some of you all. If the projection is not exactly what happened when we did our run-through on Friday, so you're getting to see my presenter view. I hope I don't have any inappropriate comments in my notes. Those are supposed to be for my eyes only, so I may be surprised as you but we will go with what we have now, and we'll get it fixed by the time. This is a 4-part series. We'll skip next week, and then have 2 weeks where I'll be with you. And the 4th week, Amy Weatherup from via Partners will be coming to share her personal story as a cancer survivor. But this topic feeds my soul, I guess you would say. Checks all the boxes, because we're going to be able to talk a bit about biology. Was a biology major at Chapel Hill, so I love biology. We're going to be able to talk about medicine. We're going to talk about psychology. And we're also going to talk about spirituality. And for me, that gets my wheels turning, and that really checks all the boxes. So again, it's also been a nice way for me to spend the time that I've had to spend at home. It's been a nice distraction to prepare the series for you. So I hope everyone gets something out of it. Again, this is interactive. I would love to hear from anyone willing to share, and at various times I'll have that opportunity for you. And I do believe the presentations are being recorded. We know these summer series, it's impossible to think that people can be here every Sunday. So we plan to record the summer series and have it available by a link, and we'll be providing that to anyone who would like it. So you can see that, I'm a teacher. And I like, for my students, when I talk to them, I like for them to know what to expect. And we're talking about navigating a cancer journey. So I continue with what I usually do when I start talking with people, is to give you an idea of what we're talking about today. So this is the roadmap for today. We're going to talk about what is cancer, how the diagnosis changes everything, dealing with the emotional dimension of cancer, and also beginning to talk about becoming more informed. So there are 2 books, as Jay mentioned. The first book that really Stephen Ministers will be very familiar with, Dr. Haugk, who is founder of the Stephen Ministry Program, who's out of St. Louis. He is both pastor and also clinical psychologist. And those of us who have been through Stephen Ministry training know how thorough he is in his writing, and also how well spoken he is, and it's very, I think, what the heading of the book says, a practical guide to those with cancer and for their loved ones. So I would see Stephen Ministers who maybe were working with, have been assigned a care receiver that might be dealing with that diagnosis, or maybe a family member, that this might be a book that they would be interested in as a resource. And we do have copies available in the Stephen Ministry Library, and certainly copies are available for purchase through Stephen Ministry, but also through Amazon. I got mine in the next day, ordering on Amazon. So these are 2 very different books. Again, this first book is very practical, very comprehensive. It's an easy-to-use guide. It's not really meant to be read from cover to cover. It's meant to be a resource. So you look in the table of contents, find what you're looking for, and then go to that. The other book, The Emperor of All Maladies. Has anyone read this book? Lynn has. And there was also, okay, good. There was also Ken Burns series on PBS, a 6-part series, and those of you who are familiar with his work, he does an excellent job. Bob and I tried to find the series on PBS or online the other day, and we found clips of it. I could not find the intact series. You could order it on a disc, and not many people even have the ability to play those discs anymore, but we'll continue to look for it. But again, this is a different book, and this book I have listened to over the course of the last few weeks on Audible. And let's just say, first off, it's the winner of the Pulitzer Prize. It was published in 2010, And interestingly, in November 2025, it's going to be, a new edition will come out that will have 4 additional chapters. Because things have changed since 2010. And so I am really looking forward to Dr. Mukherjee's updated version that will include some of the new, exciting, hopeful, promising new treatments for cancer. So I would not go out and run to purchase this yet. Wait till November 2025. People describe this book as ambitious, as brilliant, as riveting, intensely readable. I will say it reads like a novel, and it is a biography of cancer. If you're interested in history, you would love this book. It reads so well. It's wise and a deeply human piece of writing. Those are some of the descriptions. And so, again, I highly recommend it. It is a treat. It's long. It's up there too.
Yeah,
it is long. But it is quite well written, and for Audible, it's very well narrated as well. So that's kind of the foundation, and this is a quote from that book, The Emperor of All Maladies. And I guess it spoke to me because it's not just talking about cancer, it's talking about illness. And I'm gonna read it, and then I'm gonna have you all, if the focus is okay, read some other things. But this one is from Susan Sontag. She died in the early 2000s, I believe. She was an activist, an essayist, a writer. She wrote a book called The Metaphor of Illness. But this quote spoke to me. Illness is the night side of life, a more onerous citizenship. Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later each of us is obliged, at least for a spell, to identify ourselves as citizens of the other place. The imagery of the passport, and I have certainly been traveling in that other realm recently, and can really relate to this quote. Let's look at this. What do you see here? What is this?
Crap.
Cancer.
Blue crab.
Cancer, and so you already, Dave, are associating cancer and this image of a crab, right? And this, the crab is the symbol for cancer. And in 400 BC, you might see that the cancer is derived, we'll look at my notes up there, cancer is derived from the Latin translation of the Greek word for crab, and the Greek word for crab is carcinoma, okay? And that sounds a whole lot like carcinoma, which is another term for cancer. This is in the time of Hippocrates when we see this first word used, and it appeared in the literature of the time. And Hippocrates described tumors or growth, a cancerous tumor, with a center, like we see here in the crab, and with appendages coming out. And he likened that to the real view of cancer with a center and extensions coming out. Now there's been plenty of embellishments of that metaphor since then from patients and doctors and writers. What about this image reminds you of cancer? And we laughed a little bit about this when I was running through this presentation on Friday. Law was here, and I asked, "What do you see?" And he said, "A crab. It reminds me of Maryland, because that's where he's from." And he said, "It reminds me of food." And I thought, well, that's Law. He loves food, and that's what he saw. Anybody else have any thoughts on on this and its relationship to cancer?
He's got a lot of legs that kind of spread, and you think of cancer spreading
Yeah.
cells.
You do think of cancer spreading and sort of having extensions going far and wide. I think of little sand crabs at the beach who, there's numerous ones of them, and they can bury themselves, and then all of a sudden they pop up, and then they can bury again. The other thing, anybody else see something?
I was just gonna say, I grew up in Norfolk catching blue crabs,
Yeah.
and they hold on. Now you throw a chicken neck on a
Oh,
string, and they
gosh.
hold on like crazy.
That's-
You know, and that's how you pick them out of the water and stuff.
That's amazing. And some people connect the pincers with pain. And certainly, some cancers more than others are associated with a great deal of pain. The hard shell case. Again, some things as a clinician or as a student, I learned that when you're feeling a mass and it's hard, especially like a mass in the prostate, for example, that's concerning. A hardened mass versus a softer mass. So I appreciate the metaphor, I appreciate the imagery, and it's been around for a long time, since 400 BC. So let's talk about what cancer is and what it's not. Back to the passport idea of the realm of the well and the realm of the sick. Some folks, probably everybody in this room, either themselves or a loved one or a friend has experienced cancer. So I would say some people have this image stamped on their passport. So what's cancer and what is it's not? And we use the term tumor. You know, someone has a tumor, a brain tumor, or a tumor in their lung. So what's a tumor versus what's a cancer? And one thing that we do know is that tumors by themselves are just growths. So if someone says, I have a tumor, you don't really know technically if they have a malignant tumor, which would be cancer. What you see on the right side is cancer, a malignant tumor. Or someone could have a tumor, growth, that is benign, that is not malignant. So when we talk about cancer, we're just talking about malignant tumors. And this is one of the slides I use for my students at the very beginning of our discussion of cancer biology. Well, how do you tell the difference? What are the characteristics of each? And, you know, head to head, they're pretty different. You can see that benign tumors grow slowly, okay? And malignant tumors grow rapidly. Benign tumors, and by benign I don't mean good, you know, benign tumors can be life-threatening. And we'll talk a little bit more about that. But benign, if I had a choice, do you want a benign tumor or malignant tumor? I'm gonna take a benign tumor every day. Benign tumors have a well-defined capsule, and that's really makes it easier for these tumors, depending on their size and where they're located, to be removed, surgically removed. They're intact, they have a border, they have a capsule, well-defined. Malignant tumors may be not encapsulated at all, have no capsule, or have capsules that have compromised integrity in some way, a capsule that's breaking down. Benign tumors are not invasive. They don't have the extensions that are extending out into other tissues. They're intact, capsulated, not invasive. Malignant tumors are invasive to local structures around the mass of cells around the tumor, and invasive to tissues. Benign tumors are really well differentiated, meaning when you look under the microscope and you see a biopsy, you see the cells. The tissue of a benign tumor will look like the tissue where it arose. So if it is a breast cancer and a breast biopsy and it is benign, it looks like a breast cell. Breast cells don't look like lung cells. So again, under the microscope, you can tell it's well differentiated. In contrast, the malignant cells are very poorly differentiated, and you may not even be able to recognize what kind of cell it is. Maybe the pathologist sees on the report that it came from the lung, but without that report, there would be no way looking at it to say, oh, that's a lung. That's a lung tumor. So very, very important differentiation there. If you remember your high school, college, maybe even middle school science, you probably at one time learned about mitosis and how cells divide and reproduce. And benign tumors have a really low mitotic index. They don't divide. Dividing cells are rather rare. Contrast with malignant tumors, they have a very high mitotic index, many dividing cells, and these are things, again, a pathologist can see under the microscope and actually determine a number that goes with that mitotic index. Benign tumors do not metastasize, and you know what that word means. That means metastasize, the cancer moving usually through the bloodstream or the lymphatic vessels to a distant site. Benign tumors do not metastasize. Malignant tumors have the ability to metastasize. Not all cancers metastasize. The later the stage of the cancer, we'll talk a little bit about staging the next time we're together, but the later the stage of cancer, the more likely one of the things that goes with that later stage of cancer, stage 4, for example, is that it has moved to a distant site. It has traveled, and again, that movement is usually through the bloodstream or through lymphatic vessels. And then, again, just another comment about those benign tumors. Benign doesn't mean everything's great. They can get extremely large. They need to be removed, and depending on the location, it can cause a lot of symptoms and be life-threatening, especially tumors in the head. You know, we have a very confined space here within our skull, and any kind of growth of any size is going to impinge on functional brain tissue around it. And so it may be a benign tumor, but it may cause a lot of problems. Okay. So cancer is a disease that causes uncontrolled growth of a single cell. All of this excessive growth, about growing rapidly, a lot of cell division, that growth is unregulated. In a normal cell, there are genetic circuits that manage that growth, that make that growth normal, and that make that cell functional. And again, when cancer, the growth we see is those normal protective circuits are broken. And when the circuits are broken, the growth is unrestrained. And now you have a cell in the lung that doesn't look or act anything like a regular lung cell. We'll talk a little bit more biology, but let's look at American Cancer Society projections for 2025 and just talk about the prevalence of cancers. And these are, American Cancer Society keeps some very good statistics. These are estimated new cancer cases for this year. And you can look on I know it's hard to see up here, but the top two estimated new cancer cases in volume are breast cancer and prostate cancers. Breast cancer and prostate cancers are common cancers, okay? Following breast cancer, and remember, men get breast cancer too. So this includes male and female breast cancer. So the numbers there for 2025 are 319,000 plus for breast cancer and 313,000 for prostate cancer. So these reproductive system cancers are very common and lead the new diagnosis. After that is lung cancer, lung and airway cancers, And then comes colorectal cancer. And I don't know if you're aware, we'll look at it again a little bit more next time, but there's a worrisome trend right now, a worrisome trend of colorectal cancer in young people. If you're familiar with Kate Bowler, stage 4 colon cancer, in her 30s. And we're seeing my son, one of the best man at his wedding, and 41 years old, just diagnosed with colon cancer. We're seeing a really worrisome trend of colon cancer, and it's led to some changes in colon cancer screening. Do you know the age now when you're supposed to get screening? It's now 45, it was 50. And if you have colon cancer in your family, it needs to be earlier. So again, colorectal cancers are coming up, estimated new cancer cases. Then we have skin cancers. Remember, skin cancers, this is the 5th bar down there. Skin cancers include basal cell cancers, which are not part of these statistics. Those don't spread. They're cancers. They're malignant cells, but they don't spread, and they're very treatable. And if we included all the instances of basal cell cancers, that number would be off the charts. So they just include in these skin cancers melanoma and also squamous cell cancer. And then if we go to cancer deaths, that's the number one reason that people are estimated to die from cancer in 2025 is lung cancer. And it's been lung cancer for a while, especially since the 1950s, 1960s. That was the height of smoking cigarettes, and there is no doubt a direct connection with that. So we're starting to see it fall, but still it's the number one cause of death amongst the cancers. Then comes colorectal cancer. Then comes pancreatic cancer, something that didn't show up on even the new cases. So it's rather rare, but it's often diagnosed pretty late stage before someone has symptoms and know they have it. And so it has a higher incidence of mortality. And then comes breast cancer and prostate cancer. So just a little bit of use of statistics there. The other thing I want to emphasize before we talk about some of the emotional things connected with the diagnosis is cancer is a genetic disease. And I don't necessarily mean genetic like Down syndrome or cystic fibrosis. It is rare that there's just a single gene on Huntington's disease. It's rare that there's just a single gene that causes a cancer. Usually, and I've highlighted here, it's multiple genetic changes during the course of somebody's lifetime. So not necessarily something inherited directly from a mom or a dad. But first off, cancer is a genetic disease, and genetic changes or mutations drive cancer. And again, it's cumulative. So we know, for example, for colon cancer, we know the mutations that are involved that change a benign polyp to a malignant cancer cell. Now that we know much more about the human genome, we know the steps that go through from that polyp to that cancer. And that takes time. So that screening that happens now at age 45, if that's clear, when will the person come back for the next screen?
10 years.
10 years. Why 10 years?
Slow growing.
And that's the time period that it takes for a polyp to go through the consecutive cumulative changes to turn into a malignant cell. So if the polyps are seen at that first screen and they're removed, you know that there's not going to be progression to a malignant polyp, at least for 10 years, okay? So usually our screening guidelines, there's some science behind picking, what that time period is. The other thing, so cancer's a genetic disease. It's usually a disease of cumulative genetic changes that occur during aging. So it's also a disease associated with aging. And I know I took care of children, I took care of 2-month-olds with leukemia. And I'll have to read this to you. This is incidence of cancers by age. And here's our youngest, our less than 1-year-old, 1 to 4. Here are the children. And you see, again, as heartbreaking as it is, and the St. Jude telethons and the imagery that we have of children with cancer, it really makes up a low percentage of individuals who have cancer. And you can see as people age, the incidence gets higher. This slide, or this information is a little bit dated, but it really hasn't changed much, and this is good graphics, so I've included it. But you can see the peak of cancer here is in this age block of 65 to 69, okay? But it doesn't keep climbing. You see now, after that peak, age 65 to 69, we start to see it go back down. So I think this is an interesting statement. Paradoxically, our adults, our 89-year-olds, our 92-year-olds, our 100-year-olds, those adults with the longest longevity are less likely to develop cancer. So we don't see aging as, it is a natural process. It's not inevitable that you age that you're going to get cancer. Old age does not necessarily lead to cancer. But again, pretty striking that the people, if we're talking numbers, the people most affected by this disease are going to be an older population. Again, that worrisome colorectal cancer that's happening now in the 40s and the 50s. A younger population. Yes, not your 70-year-olds or your 60-year-olds. Again, those genetic changes may be mutations in the DNA, the genetic code, alterations in that sequencing, that affects the expression of that gene or the function of the gene. Or these genetic changes can be caused by what we call epigenetic mechanisms. Epigenetic mechanisms don't involve the sequencing, don't involve the DNA sequencing of amino acids. They involve changes that affect the other parts that's kind of holding the DNA strand together. And some of the things that affect changes in epigenetically are carcinogens. The cigarette smoke, the pollution. Globally, pollution has a real impact on cancer cases in the world. We know about cigarette smoke. We know about certain chemical dyes causing bladder cancer. We know about more and more about diet and the things that we eat and we put into our bodies can cause epigenetic changes. We know about the gut biome, the bacteria that inhabit our GI tract that are really in the right balance, keep us healthy. And alterations in that gut biome can also lead to these changes. So multiple things can contribute to these changes. How old is cancer? You see, I've got images here of the Egyptians and the mummies. So we do have evidence that of writing, at least storytelling, at least as far back as 2,500 BC. And this was an Egyptian physician who didn't visualize cancer, but under the microscope, of course, but reported, he was a, quote, physician of the time, and reported incidences of, I think his first case was a woman that had a breast cancer lesion. Very visible, very hard, and he made a description. It was discovered in a papyrus. These descriptions are 48 cases, and they almost read like a surgical textbook. He used the anatomical terms appropriately. It's pretty incredible, where he would describe the patient, their age, 31-year-old female, etc., and to describe what he saw. And also, in most of the cases, in all of the cases except one, he would describe the diagnosis and what the treatment was for. So he would describe a femur fracture. He would describe leprosy. He would describe and diagnose and treat. Now, treat in those days was sometimes magical, sometimes occultish, but he would put something down for treatment, except for case 45. And case 45 out of the 48 was the breast cancer lesion. And he put in the treatment column, there is none. So even some recognition early on that cancer had an aura about it, that it wasn't like other diseases, and that again, certainly in that time, and that's what's so encouraging about now. There are treatments, and we'll talk a lot about that. Another storyteller was a Greek historian. I'm not going to go into too many details of his story of a queen of Persia. She also had a brain cancer, and rather than, she had all the physicians at her disposal, and she chose to wrap herself in sheets and to go isolate. She finally broke down and had a slave that she trusted, and she asked him to excise the lesion. She survived that crude excision, and at least lived for a time. And because of her status as queen, this, in some way, those of you who are students of history would understand this more, but that really changed the course of history. This beloved slave wanted to go back to Greece. This queen was in charge of an armada of ships getting ready to take over parts of the world, and they headed to Greece because of her honoring the slave's wishes to go in that direction. But those are storytellers. Written storytellers, we do have, again, physical evidence. Paleontologists have unearthed mummies and have found cancer in preserved mummies, both in the deserts of Peru and certainly in Egypt, so where they can look under the microscope and actually see the cancer, not just hear about it in the story. So cancer is old, in other words. We tend to think of cancer maybe more as a modern disease because we hear about it more today, and there's certainly more incidents of cancer documented today, but really it's quite an ancient disease. So Dr. Haugk in his book starts off with how the diagnosis of cancer changes everything, and he wrote this book because his wife was diagnosed with breast cancer, and they went on the journey together. and he decided that he would write a book about their experience. He also brought in a lot of experts in the medical field and in the research field, in the psychological field. So again, these are some of the quotes from this book. I couldn't believe it. I just kept hoping someone would say it was a mistake. I trembled all over and just couldn't stop crying. I was in shock. My eyes glazed over and my mind went blank. Whatever the doctor said after that one word cancer might as well have been in another language. I was furious that my own cells had turned against me. I think we can hear in those words people's reaction to cancer and how it can turn their world upside down. So here we see some of the descriptions again, the feelings that come up, the emotions that come up. And I'd love to hear if anyone has any other ones besides these, but disbelief and shock and sadness and fear, denial, anger, people feeling helpless and confused and scared. Anything else come to mind that's off the top of your head? Yeah.
Well, Becky, when, it's been back in 2001, I guess, when I was diagnosed with breast cancer, I had a number of biopsies in the past, you know, and they were always fine. So when I had this one, it was my doctor, it was the way he came into the office, into the examining room, after I'd had the biopsy and I had to go back in for a checkup, and he came in and he said, "I'm really surprised, but there were cancer cells in the biopsy." And it was the way he told me, which was so gentle, and I was kind of like, okay, now what? And he said, "Just get dressed and come and talk to me." And while I was getting dressed, I was praying that I would have a sense in my mind that I would hear him.
Mm-hmm.
And so I went into his office and I felt calm. I mean, it was not any of these at that time. It might have been later, but at that time I felt very confident because he was just
The way it was
surprised.
presented.
The way
to
he
you.
presented it, and then I had a friend who had been through this too, so I actually felt calm
Yeah.
and confident.
He was calm.
Because he was gentle, he was very gentle. Dr. Turk, if anybody knows Dr. Peter Turk.
Yeah.
I mean, it was just his manner of telling me, it wasn't
Right.
alarming.
Right. That's so interesting. I love, the concept of being surprised.
Mm-hmm.
The surprise is different than being shocked. It has a different connotation, and it shows. And we'll talk more about interacting with the medical team next time we're together. But it makes such a difference when you have someone who gives you that confidence, that calm. Yes, you've got this thing, but we can work with it. Let's get on it. And again, not providing false hope. We have a saying in medicine: hope is not a plan. Hope is good. Prayer is good, but let's have a plan. But these are and Stephen ministers, I don't know when you will meet a care receiver that is going through this journey. You might meet them at this stage. But again, it might be at a later stage where some of this has gone away. I think that afterwards, I won't read these quotes, but afterwards, some of that confusion fades and people are able to think more clearly. And then there's the roller coaster, the ups and the downs during treatment. Some days feeling normal, some days feeling lousy, some days getting good test results, some days getting, test results that are not good. Some days hearing that you're in remission and the cancer is not evident. Other days hearing there's a relapse and it's come back. And it's this up and it's this down. And so people need to be prepared for that, and I don't know when Stephen ministers, if you have a care receiver with cancer, I don't know when you'll see them, where they are on their journey, but I think it's important to recognize that they can be in different spots, okay? Words of encouragement rooted in experience, and these are Dr. Haugk's words. Remember, his wife, he's just gone through this. And I'll say that this is also my experience working with families who have children with cancer. The mind will become clearer. Your focus will sharpen. You will become more knowledgeable. You will learn much of the medical language, and you'll certainly gain a better understanding of the healthcare system and how to work with it. So, again, I think words of encouragement are important when we're supporting someone, and also taking in ourselves this diagnosis. It's important to be encouraged that that shock stage, if it's there, probably won't be there forever. Statistics are numbers, they aren't people. You all know this. And so here's an example. The statistics showed I had 30% chance of living 5 years, and that was 27 years ago. Statistics are data gathered that is useful, but only based on past. Statistics are not predictive of an individual's mortality, we'll just put it that way. They're just numbers. They're useful. And one of the ways that that we find them useful, you know, I said it before, pancreatic cancer, not that common, but has a high mortality. That's from statistics that we know that. But that doesn't mean that everybody's path is the same. The other thing about statistics is they can help us understand progress. So again, in the 1940s, childhood leukemia, particularly ALL, acute lymphocytic leukemia, the survival rate was 5 to 10% in 1940. And today, that survival rate is greater than 90%. 90% of children diagnosed with ALL, the most common age for ALL diagnosis is 5 years old. 90% of those kids are surviving after 5 years, and so many, we hate to brag on cures, but many of that 90% have normal lifespans. Okay, so that's where statistics are helpful. The 1940 standard of care was supportive care, radiation only. The 2025 standard of care is chemotherapy, targeted therapy, immunotherapy, bone marrow transplant. Some of these things we'll talk about in other sessions. Telling others about cancer, again, meet your own needs. If you are the person who has the cancer, you tell who you want to tell. You determine the narrative, and you determine how much you share. And these are just some examples of it's okay to let your emotions show. Maybe consider having someone with you when you tell certain people if you think that would be easier. Maybe you ask someone to tell others for you. Maybe you don't need to share every detail with every person. And maybe you need to set boundaries about what you do share with somebody and what they're allowed to share with someone else. Stephen ministers, we're all about confidentiality, and we know that instills trust. And if someone is confiding their story to you, that doesn't mean you're free to share it to the world without their permission. Choose the best means of communication possible, whether that's in person, perhaps a phone call. Caution about social media, because it never goes away. And, you know, again, common sense, consider the right time and the place, and be prepared that people will react differently to the news. So the teenager who's hearing it from a parent may not react like you expect. So people will react differently, and at the end of the day, just go easy on yourself. We do know that some of the things, this is the quote, while waiting for the biopsy results, I realized that one of the things I was most afraid of was the prospect of telling people that I had cancer. All right, I have promised that we're gonna get people to church, so that's where we're gonna stop. We'll have a little bit more on, this roadmap to cover next time, just a little bit. And next time that I see you, we're gonna be talking more medicine, more about the therapies, more about working with the medical team, caring for yourself and others, relating to those families.